Welcome to Hand Surgery Resources YouTube video on Kaplan's line, the topographical lines of the palm, and the surface anatomy of the hand and wrist. The first part of this video will discuss the bony landmarks that help us identify the location of structures in the hand and wrist. So the first bony landmark that's easy to visualize and palpate is the distal phalanx, which goes from the dorsal crease of the DIP joint to the tip of the finger, also from approximately the volar crease distally. Underneath the top portion of the distal phalanx is the extensor tendon, the terminal extensor tendon attaching to the dorsum of the distal phalanx, the nail obviously, and the nail fold structures. On the palmar surface of the distal phalanx, there's the pulp and the insertion of the flexor profundus into the base of the distal phalanx are going to be present on the radial and ulnar aspect of the distal phalanx. And again, the distal phalanx is going between the joint and the tip of the finger. Bony structure is easily visualized is the middle phalanx, which goes from the DIP joint to the PIP joint. The skin is thin, and right under it is the extensor tendon, with the lateral bands coming up on the side to join the extensor tendon as it goes out to the distal phalanx as the terminal extensor tendon. On the mid-lateral portion of the middle phalanx, above the creases, is the neurovascular bundle, both radially and similarly ulnarly. On the palmar surface of the distal middle phalanx, which again is between the PIP and DIP creases, we're going to have under the skin fatty tissue, and then the flexor tendon sheath, which will include the profundus passing out to the distal phalanx, and the flexor digitorum superficialis, which inserts into the base of the distal phalanx. Is the proximal phalanx, which goes from the MP joint to the PIP joint. Again, the skin is present on the dorsum with a thin layer of subcutaneous tissue, and under that is the extensor tendon. The common extrinsic tendons are going to be coming from the MP joint down the center. The lateral bands, i.e. the intrinsic tendons, are going to come in from the sides and join together over the proximal phalanx and the PIP joint to form the extensor hood. On the sides, we're going to see the creases, and at the top of the creases of the neurovascular bundle on the radial and also the ulnar side of the digit. On the palmar surface of the middle phalanx, it's important to note that the level of the web, it goes through the middle of the proximal phalanx, not really the base of the proximal phalanx. Again, we said from the dorsum, the proximal phalanx went from the MP joint to the PIP joint. The MP joint is just a little distal to the palmar creases down where my finger is located. So again, the proximal crease of the finger is at the middle of the proximal phalanx. Underneath the skin is the fibroosseous tunnel of the flexor sheath, which encloses the flexor profundus and the flexor superficialis. The next bony structure that we will easily identify from the surface anatomy is the distal phalanx of the thumb, extending from the IP joint to the tip of the thumb. Underneath the dorsal skin is the terminal insertion of the extensor Palmaris Longus, obviously the thumbnail, and the surrounding nail fold tissues. On the side of the thumb, on the radial side, there's a neurovascular bundle coming just above the crease, and similarly on the ulnar side, a neurovascular bundle. The palmar surface of the thumb, distal phalanx going from the crease to the tip, we have the pulp and the insertion of the flexor Palmaris Longus tendon. The phalanx of the thumb is located between the IP joint and the MP joint, between the thumb and my index finger. The extensor Palmaris Longus is extending underneath the skin here, going out to the distal phalanx. Right at the base of the proximal phalanx, the extensor Palmaris brevis inserts into the capsule, which then inserts into the base of the dorsum of the proximal phalanx. The side of the thumb, radial aspect, shows again the flexor creases, and the neurovascular bundle will be on the mid-lateral line right above these creases. Similarly present neurovascular bundle on the ulnar aspect of the thumb. On the palmar surface of the thumb, palmar and volar to the proximal phalanx will be the fibrosus flexor tendon sheath of the flexor Palmaris Longus tendon present. At the MP crease is the classic area where the FPL can be involved with tenosynovitis and trigger thumb diagnosis. The next bony landmark that is evident on the surface of the palm side of the hand is the trapezial ridge. It is not easily visualized but easily palpated. If we have the patient flex the wrist against resistance, we can see the flexor carpi radialis longus, and as it gets to the distal crease of the wrist, it goes under a bony ridge, i.e. the trapezial ridge, which is present right here and extends a little further out to the base of the metacarpals. Pinch like this. The thinner muscles seen here as the patient pinches are partially originating from the trapezial ridge. Also, we see the palmaris longus in this person's hand. Next bony landmark on the palmar surface of the wrist and hand that's easy to palpate is the pisiform. If you have the patient flex against resistance, you can see the flexor carpi ulnaris, and as that tendon goes out to the base of the hand, you'll feel a bony point that the tendon connects to. That bony prominence is the palmar aspect of the pisiform. On the radial side of the pisiform is Guillon's canal, where we'll find the ulnar artery and ulnar nerve. The pisiform moves back and forth during flexion extension, but we can also elicit tenderness in the pisiform triquetral joint by subluxing the pisiform radially, which will produce tenderness if there's arthritis, for instance, in this joint. Just distal to the pisiform is the hook of the hamate, which is another bony landmark in the hand. To palpate the hook of the hamate, one starts by having the patient resist you as you test their volar flexion, identifying the extensor carpi ulnaris tendon. Use that to follow out distally a little bit, relax the hand, so that you feel the pisiform. Then you place the flexion crease of your IP joint right at that pisiform junction, aim towards the base of the ring finger, and you will be pressing on the hook of the hamate. And the hamate, then being approximately here, is going to help us localize the distal portion of Guillon's canal, which includes the ulnar artery and ulnar nerve. The artery will extend out into the common digital artery. It will also send a branch around the hook of the hamate going dorsal as it goes radial to join the deep arch in the mid-palm. Similarly, the ulnar nerve will split into a motor branch going in the same direction and sensory branches coming out to the ring and radial aspect of the little finger. Another commonly palpated bony prominence and landmark in the wrist-hand area is the tuberosity of the scaphoid. If we move the metacarpal, we can see where the CMC joint and have the patient flex against resistance, find the flexor carpi radialis again, and right under it, relax, you're going to feel a bone, which is the tuberosity of the scaphoid, just proximal to the trapezium. Tenderness in this area can be because of tendinitis of the tendon, which you're pushing against in order to push against the bone, or it could be because the bone itself has an injury such as a distal scaphoid fracture. The waist of the scaphoid can be palpated through the anatomical snuff box. If the patient extends the index and thumb, you can feel a defect here, the so-called anatomic snuff box, between the base of the thumb and the radial styloid, with the EPL on the dorsum and the abductor on the palmar side of this so-called snuff box. Relax. In the snuff box, I'm palpating the waist of the scaphoid. Crossing the waist of the scaphoid is the dorsal branch of the radial artery, which comes up here to the junction of the thumb metacarpal and index metacarpal, then passes deep into the hand to supply blood to the deep arch. The radial pulse can be felt in this dorsal arch area, and is a good way to tell if the artery is intact after an injury in this level, because if the pulse is going up, it's probably intact unless it's retrograde flow. An additional landmark is Lister's tubercle. It's difficult to see in many individuals, but not difficult to palpate. If one extends the thumb and you follow the EPL, you can see it going right to the ulnar aspect of the Lister's tubercle, which acts as a bony fulcrum for this tendon as it passes through the dorsum of the thumb. On the ulnar side, therefore, is the EPL, and on the radial side are the wrist extensors, extensor carpi radialis longus and brevis, going through the second compartment of the wrist extensors. Lister's tubercle is also a useful landmark because, relax your wrist, just distal to the Lister, here's Lister's tubercle, just distal it, there's a soft spot, and that is an area where typically there is ganglions occurring, but it's also the 3-4 portal for wrist arthroscopy, i.e. an area where you can put a scope into the wrist with some ease and safety to visualize the internal wrist structures. Just distal to this softer area and in the proximal row is the junction of the scaphoid and the lunae, i.e. the scapholunate ligament. So if one palpates Lister's tubercle, slides distally into the soft spot there in the portal area, just a little more distal, and palpates, you'll be eliciting tenderness of the scapholunate ligament, and if it's acutely torn, there's obviously going to be tenderness in this area. An additional bony landmark in this radial aspect of the wrist is the radial styloid. If the patient extends and abducts the thumb, again, the snuff box is here, following the abductor route, you'll be right on the radial styloid, and palpating in this area will identify tenderness in the first extensor compartment. If we go just a little volar on the radial styloid, we will palpate easily the radial artery as it passes over the volar surface of the radial styloid. The radial aspect of the wrist, the radial styloid, represents the proximal edge of the so-called anatomic snuff box, which is located right here. The other aspect of the wrist, a bony landmark, is the head of the distal ulna and the ulnar styloid. If the patient ulnarly deviates and extends the wrist against resistance, you can easily palpate the extensor carpi ulnaris, which passes right over the ulnar styloid. Below the extensor carpi ulnaris, there's another soft area. Through that little groove, you can palpate the TFCC and the triquetrum. As we said, relax the hand, the radial styloid right here and the ulnar styloid right here are easily identified bony landmarks that are part of the superficial surface anatomy. These 2 points can be used to identify the difference in length in the radius and ulna, and therefore are useful landmarks when checking the patient after a closed reduction of a Colles fracture to see if you have regained the length of the radius. The radius should be longer than the ulna in most individuals, and here you can see the tip of the radial styloid is definitely longer than the tip of the ulnar styloid in this normal patient with no deformity. Finally, when visualizing the dorsum of the hand and wrist area, when you're trying to palpate the joints, typically the joint is just a little distal to the bony prominence that you palpate easily, which is the head of the middle phalanx in this case, the head of the proximal phalanx in this case, and the head of the metacarpal at this level. In the thumb, this is true in the IP joint, where the IP joint is just a little distal to the proximal phalanx head and a little distal to the metacarpal head. The exception is the thumb CMC joint, where the base of the metacarpal is typically more prominent than the trapezial portion of the joint. So when you're trying to find the CMC joint, it's easy to palpate it by going along the surface of the metacarpal until you reach a tiny step off, and then you'll be in the CMC joint. The skin creases are also useful guides to the location of deeper structures. The skin creases can also help us see visible landmarks when we're trying to identify underlying deeper structures. The distal flexion crease of the digit is just slightly proximal to the DIP joint. The creases of the PIP joint area are typically just a little proximal to the PIP joint. The crease at the base of the finger, however, is not in line with the joint. It lines up with the web and the middle of the proximal phalanx. In the palm, the distal palmar crease and the proximal palmar crease are present over the necks of the metacarpal bones. If you put a line from the ulnar border here of the distal crease to the ulnar border of the proximal crease, that line will be essentially right over the neck of the index, long, ring, and fifth finger metacarpals. The interthenar crease travels down over the base of the long metacarpal and over the carpal tunnel. The IP crease of the thumb is located essentially over the IP joint. The proximal crease of the thumb is located almost in everyone over the MP joint of the thumb. In the wrist, there is usually a distal and proximal crease. Here we see mostly the distal crease. The distal crease typically will cross the waist of the scaphoid and the center of the pisiform. Again, this is the line of the distal flexion crease of the wrist. In this section, we will review Kaplan's line and the other topographical lines that help identify structures in the hand and wrist. In addition to the obvious creases that we see in the skin of the hand, there are some other topographical lines that can be drawn to help us localize deeper structures. The most commonly known one is the Kaplan's line. Kaplan's line goes from the apex of the web, essentially at the ulnar aspect of the crease of the MP joint of the thumb, to the hook of the hamate. And again, one finds the hook of the hamate by first finding the pisiform and then putting the tip over onto the hook of the hamate. So that's approximately here in this patient, and again, the apex of the web is there. So this sets up 2 points making a line, the Kaplan's line, which we'll put on this patient with a marker, is approximately in this area. Now, this Kaplan's line, or so-called Cardinal line, is going to cross over the motor branch of the median nerve and go to the hook of the hamate. If we add a second line from the ulnar border of the ring finger to the hook of the hamate, this will help us identify additional structures. And a third line from the radial border of the long finger back to the tuberosity, the scaphoid, and the flexor carpi-radialis tendon. So again, this is the third line. And where this line crosses the cardinal line is quite close to the area of the motor branch of the median nerve. A fourth line is placed from the ulnar border of the distal palmar crease to the radial border of the proximal palmar crease. You set up a trapezoidal space which includes a superficial vascular arch, and just proximal to Kaplan's cardinal line, the deep arterial arch. Where the line on the ulnar aspect of the ring finger across the cardinal line is the area of the hook of the hamate. On the ulnar aspect of the hook is going to be Guillon's canal, which includes the ulnar artery and ulnar nerve. And on the radial side is the carpal tunnel structures. Additional topographical lines that may be helpful is a line from the base of the little finger to the hook of the hamate. This line is basically the line over the ulnar neurovascular bundles of the fifth finger. Similarly, a line from the radial base of the index finger to the point where the cardinal line crosses the line on the side of the long finger identifies the radial neurovascular bundle to the index finger. To identify the midlateral line, first identify the top of the creases on each side of the finger. Here we see the proximal finger crease dorsal point, the mid crease dorsal point, and the distal crease dorsal point, and then the edge of the distal palmar crease. So if we then connect the dots, we will produce the midlateral line of the digit. Just below this midlateral line is located the neurovascular bundle, which will travel approximately in this area. This final finger photograph with the mid-axial line identified shows the location of the digital artery in red, and just volar to this, the white line representing the digital nerve. Next, we will review the landmarks on the dorsum of the hand and wrist. The surface anatomy of the dorsum of the hand and wrist is easily visualized because the skin is loose and thin in most individuals. Here we see the dorsal veins are obviously visible. The extensor tendons, when one extends, are present. Here's the extensor tendon of the little finger, ring, long, and index. This is demonstrating primarily the extensor digitorum communis. If I do like this, you see this slightly curving extensor. That's the extensor indicis proprius, and this is the extensor digiti minimi. In the thumb, extension shows the EPL easily, and a little less easily the extensor pollicis brevis extending out to the MP joint. In addition, if the patient makes a fist, you can still see the extensors, but you also see and palpate a tendinous connection, usually between the long and ring finger and ring and little. This is called the juncturia tendinum and can extend a finger even when the extensor tendon is damaged more proximally. Also visible on the extensor surface is the first dorsal interosseous muscle. Push against me. We can see this bulge, which is basically right in this area. That represents the first dorsal interosseous muscle, and it's the last muscle innervated by the ulnar nerve and helps identify ulnar motor function as being absent or not. The palmar surface, let's see, pinch like this. If the patient pinches and we palpate the dorsal edge of the metacarpal, if we just fall off the edge of the metacarpal, this muscle in the thenar area is the median innervated thenar muscles. So they're basically from here all the way over there. If we palpate the flexor pollicis longus, everything palmar and ulnar to that will be the ulnar innervated thenar muscles. The key points of this presentation have been the bony landmarks, the hand and skin creases, Kaplan's Cardinal line, other palmar topographical lines, and the dorsal surface anatomy. We have pointed out the anatomical variation is minimal for the bony landmarks. Likewise, we have pointed out that the skin creases and topographical line show more variation, but are still excellent reference points. Finally, all our surface anatomy tools provide useful guides, but do not pinpoint exactly the location of deeper anatomical structures. There is no substitute for careful, delicate, and precise anatomic dissection during surgical procedures. Thank you for watching our YouTube video on Kaplan's line, the topographical lines of the hand and wrist, and the surface anatomy of the hand and wrist. For more information, see Hand Surgery Primer at www.handsurgeryprimer.org, and later in the spring of 2019, see our online text, Hand Surgery Source. Thank you for watching.